Welcome back, guys. This is a tricky psych medicine crossover question. The patient looks paranoid and confused, but the real cause might not be psychiatric. So let's break it down. So we've got a 58-year-old man who is 3 days post-surgery for multiple leg fractures. He suddenly becomes short of breath. His chest x-ray shows diffuse bilateral infiltrates, and he is now confused and paranoid, insisting that the staff plan to harm him. So the question's asking, what's the most likely cause of his acute mental change? So first thing is to point out the key red flags in this question. So he's post-operative, he's short of breath, and the chest x-ray isn't showing a localized pneumonia, but rather it's showing a diffuse bilateral infiltrates. So on top of all this, he's also developed an acute confusion and paranoia. So we've got both respiratory compromise plus neurological symptoms. So this combination is super important to keep in mind as we move forward with this question. So let's move on now. So option A, pulmonary embolism. So pulmonary embolism is a common post-surgical complication. So it's tempting to pick this option, but with pulmonary embolism, we'd usually see sudden shortness of breath, pleuritic chest pain, and maybe some hemodynamic collapse. The chest x-ray in pulmonary embolism is also often normal and sometimes has like very focal findings, but it doesn't have this bilateral diffuse infiltrates that we see in this option. And so therefore, on top of this, pulmonary embolism also doesn't directly cause or is directly related to the confusion and paranoia that we have in this case. So it's less likely to be the option here. Option B, aspiration pneumonia. So sure, post-operative patients can aspirate, especially if they're drowsy or with analgesia and anesthetic, but aspiration pneumonia typically gives you a focal consolidation, and this is often seen in the right lower lobe just because of the anatomy. We won't go through all that in the video. So you don't usually get confused or paranoid from aspiration pneumonia. That is, unless they become septic. So aspiration pneumonia doesn't quite fit as the cause for this mental change. Option C, acute pancreatitis. So pancreatitis 3 days after surgery, not really. It causes abdominal pain that radiates to the back. It can also cause nausea and vomiting. However, it does not cause acute pulmonary infiltrates or neurological symptoms. So we can definitely cross this one off. Next option, we have epidural hematoma. So epidural hematoma would present with focal neurological deficits. It can also present with severe headaches and lucid interval followed by a coma. So that's like the key findings with an epidural hematoma. It's not associated with bilateral lung infiltrates, and so in this case it doesn't really explain the respiratory distress that the patient has. So this cannot be the option as well. Option E, fat embolism. So this is the correct option. So the classical findings in a fat embolism is that there's a long bone fracture or a history of orthopedic surgery within a few days, which is the case for this patient. He had 3 days post-surgery of multiple leg fractures. It's not really given in detail, but we can assume. And this has also happened within the last 3 days. So with fat embolism, the fat droplets enter into the bloodstream and they can lodge into the pulmonary capillaries and cerebral circulation. So this is what causes the classical triad, which is respiratory distress with hypoxia because of the pulmonary capillaries being clogged, and neurological changes because of the cerebral circulation being blocked as well. So you can get confusion, agitation, paranoia, and even seizures. And then another part of the triad is the petechiae rash, which is often seen on the chest. It can also be seen in the conjunctiva, though the rash might not always be present. So thank you guys for sticking around. If you found this breakdown helpful, drop a like and potentially share it with your friends, and follow us for more AMC content.